It's 10:01. So I just want to say good morning and thank you all so much for coming today, whether you're here in person or on our Zoom or live streaming. We really appreciate you all coming. My name is Julie Boris and I'm a founding member of Health Rights Massachusetts. We are a nonpartisan nonprofit organization. We're a committed team of people representing thousands of Massachusetts residents with the goal of reaffirming and protecting the rights of the people of the Commonwealth to make decisions about their own health care through proactive health freedom legislation and continuing education. So why are we here today? We're here today in order to bring together local and national experts in the fields of medicine, law, science, and ethics to discuss the pros and cons of how the pandemic has been handled thus far and how to most rationally and effectively move forward. We have an amazing lineup of speakers for you today, all experts in their field, and we're so appreciative of their time and their willingness to share their knowledge and experience. Today, we hope to gain a deeper understanding of the current situation we're facing regarding COVID-19 and its countermeasures, as well as solutions that can help all of residents of the Commonwealth. The more that leaders like you become engaged in understanding the larger picture, the more likely that we'll come through this difficult time successfully, with a minimum of harm and disruption to individuals, families, businesses, and our community as a whole. Today, we'll hear from 4 panels, each focused on a different topic. The first panel will cover protective and diagnostic measures. The second panel will cover the safety and efficacy of the COVID-19 vaccination. The third will be ethical considerations, and the fourth, rational responses. Each panel will run about 45 minutes and will be followed by a 15-minute Q&A. If you are on Zoom or live streaming, please type your questions into the chat and we will do our best to answer as many as possible. If your question is for a specific panelist, please say so. After the panels, we will hear some stories from individuals who have been adversely affected by the current approach that is being taken to deal with COVID-19. And at this time, I would love to ask everybody to just please silence your phones. And before we get started with the panels, I'd like to introduce our co-sponsor for this event, Representative Peter Durant. He shares our desire to protect the rights of the people of Massachusetts to make decisions about their own health care without coercion or discrimination. So Peter, if you want to come on up here and say a few things, and then we'll get going.
Okay. Thank you, Julie. And thanks everyone for coming out today in person and those who are on Zoom. We really appreciate all of you coming here and trying to find out information as we navigate through this pandemic. I want to thank Health Rights Mass for putting this together and including me in this. Again, this is an important topic for us all. As we sit here today, we're approaching the start of our 3rd year of this pandemic. And, you know, one thing's for certain, my wife and I, my new wife and I, always have this saying that we tend to say, which is, you know, we have no idea what the next year will bring, right? And if we go back a couple of years or 3 years ago, none of us could have predicted where we'd be a year later. And even after that, none of us could have predicted where we'd be today. So we're stuck in the middle of this pandemic. And you know, some of the things that we've learned over the past 2 years have made us stronger, right? We've come a long way. We've learned a lot about this. We've learned a lot about what works. We've learned a lot about what doesn't work. And, you know, some of the things that we've learned have made us stronger as a society. Some of those things have been able to be built on and work to make us a little more productive, work to make us a little bit more safe. However, unfortunately, sometimes some of those things have hurt as well. Some of those things have caused us to go in a direction that we probably didn't want to go in. And as a society, and as groups of people tasked with making policy, making public health decisions and public safety decisions, it's always important that we examine those things that we do. Right? We have to go back and look and see whether or not what we're doing works, what we're doing hurts people in the long run. And it's okay for us to ask these questions. In fact, it's important that we do ask these questions going forward. It used to be that in society, what we did is we took science and we dissected it. We found out what maybe was working and what maybe wasn't working. And we asked those hard questions. That was our responsibility, to ask those questions. In fact, I always, I like to say that when I probably date myself a little bit. Hey guys, I date myself a little bit when I say that I remember back in the 70s, right? One of those famous bumper stickers that we all used to see out there was question authority, right? We always used to see that, question authority. It was expected of you. This is what you're expected to do. Don't take anything at face value. It's your job to question that. But today, that same bumper sticker basically seems to say, shut up and obey. And we're moving in a direction, I think, that can be frightening for many of us, and that we're in a way chastised for not accepting maybe what's being given to us. Now, look, maybe some of those things are right. And I think we have to understand, and we have to realize that whatever side of the issues that we fall on, we may be wrong, right? We may be wrong, but we may not be wrong. And it's okay to ask these questions. It's okay to move forward. And in fact, it's our duty to move forward. So I think that's what we're here today, is to get that information, find out what's different, find out what we don't know, and ask those hard questions moving forward so that we can become better as a society that we move through. I mean, I don't think that COVID's going anywhere anytime soon, right? I remember hearing a couple of years ago, people saying we're going to have to learn to live with this. And maybe that's the case. I don't know. But we have to at least examine these issues and look at them in ways that question whether or not that's going to be what we're doing, and how's the best way to move forward. And having that robust debate is important. So I want to thank everybody for being here today and welcome you. So I'm going to introduce our moderator for the day, Janice Hudson. Janice is a Boston certified speech language pathologist of 14 years. She's gotten involved with health freedom advocacy after witnessing years of injustice and injury in a variety of treatment settings. She comes here today in support of medical freedom, body autonomy, and every individual's unalienable right to be informed and give informed consent. The thoughts and opinions that may be shared by her are solely her own and do not necessarily reflect her employer or affiliated academic institutions. And so with that, I will introduce Janet Hudson.
Thank you, Representative Durant. Hi, everyone. My name is Janice Hudson. I am very happy to be here today to serve as your moderator. That said, you did not come here to hear me speak, so I would like to jump right in and introduce our first speaker for our first panel, which is preventative and diagnostic. Tammy Blakesley. And she will be here in person with us today. As you will see, some of our speakers will be on Zoom. She's the president of Environet, a Massachusetts-based health and safety consulting company. She's a graduate of Quinnipiac College with a BS in industrial hygiene and practices as a board-certified industrial hygienist. She has over 30 years of experience in product safety and OSHA, EPA, DOT compliance. She's worked in a number of settings, including chemical companies, healthcare facilities, hospitals, and biotech and pharmaceutical companies. She has conducted industrial hygiene surveys, ventilation assessments, respiratory fit testing for emergency response teams, and has authored thousands of safety data sheets in compliance with OSHA's hazard communication standard and the globally harmonized system of classification and labeling. That is a mouthful and very impressive. Without further ado, Tammy Blakesley. I'm just going to queue up her presentation. All right. Yeah, I'm just going to click. Thank you for your patience. And
this one here, yeah. This one or this one?
This one.
Okay.
So we'll show you the next slide too.
Oh, perfect. little shorter. Can everybody hear me okay? Thank you for inviting me to attend this panel. We definitely have had challenges over the last 2 years, so I do feel honored to be able at least to come out and share a little bit of my knowledge with you. And the first thing I wanted to talk about is, what is a certified industrial hygienist? Anytime I say that, everybody's like, oh, you clean teeth in industry. No, I do not clean teeth. So we want to get that misnomer out of the way first. What we are basically the Sherlock Holmes of the safety and health industry. We're a little bit kind of geeky in that we use instrumentation to actually be able to monitor in a workplace and find out what the levels are and whether they're acceptable for people to be able to be working in those. It's basically, in a nutshell, is the anticipation, recognition, evaluation, control, and confirmation of the protective measures that we're putting in place. It's basically, we want people to go home in the same condition that they came in or better. And one of the things, especially with, I just want to show you, I wanted to use one of these in the grocery stores and the post offices when I first, they started the whole, everybody needs to clean and social distance and all that. The smell of chlorine, everywhere you went, you could just feel it in your nose. And I'm like, this can't be good levels. So that would have been good to have that. But I want to share with you a story to kind of set the stage. Early on in my consulting career, I had to do a lot of industrial hygiene assessments. And one in particular that I remember is one of the hospitals in Boston. The nurses in their surgery centers that were handling a lot of pediatric patients were complaining about headaches and not feeling well and all that. So I was contracted to go in. And the first thing we did is check the ventilation, because when we look at what we do is we want to engineer out the problem. So we want to make sure that the engineering is working. Everything seemed fine. Airflow was fine. Humidity was fine. We looked at whether they were drinking enough water, getting all of those things. And then finally, we're like, well, we need to monitor in the operating room. So I went in there and brought in some instrumentation. And this is when I realized when they asked me to put one of these on, that even these loose fitting things made me claustrophobic. I'm in the operating room like, oh my God, I can't keep this thing on. And so as they're administering the anesthesia, I'm looking and I'm like, okay, something's not right here in the fact that the mask that they were putting on this child didn't fit. Now, with doing numerous fit testing of respirators and all that, if you don't have a seal, it is ineffective. So I'm looking at this and I'm like, okay, so basically what's happening is they're getting a nice healthy dose of anesthetic gases, and then no wonder they have headaches and they don't feel well. So again, when we're talking about respiratory protection, we're looking at that. So what I thought was amazing is that to me, it was painfully obvious what the issue was. But we had nurses and doctors and all of this, and you'd expect them to be able to see the obvious. And what I'm finding is that the obvious is not so apparent for people that do not have the eyes to see it. And this is where you have education, experience, and not just somebody reading an article, in a paper or a journal and expecting that they actually have the experience. So let's see. So when I look at this is the great divide over, a piece of cloth. What is it that on this side are we looking at? So I'm like, I know from the industrial hygiene perspective in my experience, but what is it that is causing people to wear all these masks? So what it said in the beginning, and even OSHA had it in their guidelines, and I was just like, this is not right. My face covering doesn't protect me, but it protects you. Your face covering doesn't protect you, but it protects me. Together we protect each other. And I'm like, this is double speak for it protects nobody. But then you get, as we go on, people saying, well, if it works even a little bit or saves one life, I'm going to wear it. And then doctors wear it all the time. I'm like, okay, so this is what we're looking at on that side. So when we look at barrier face cloths, they're not intended to provide respiratory protection for the wearer. But I think what's happened over time is that a lot of people do think that this is what's working. I had a guy in Koopman's Lumber come in, proceeded to tell me he's vaccinated. And again, I don't know why people have this desire to put out their medical status. And then he puts a bandana up, much like this. Puts this up. And he's like, oh, he goes, I like wearing it because it makes me feel better. And I said, well, it doesn't work. And he goes, well, I think it works sometime. I said, okay, how much time do you think it works? It's like 60%. I said, okay, so are we in the 60% now, or are we in the 40% that's not working? So they need to understand the efficacy of what is it we're trying to do. So when they say doctors wear them, they're wearing a medical or surgical mask. What's the intended use of those? That's for them to basically, if you have an infectious patient, you could put it on them. And then that way, if they were to sneeze, it prevents contact with that. Or when they're in the operating rooms, the amount of ventilation that's going through those operating rooms are diluting so much that there's no way that even if there was a virus in it, that it would even have, stayed in there. It's again, for the surgeon is wearing it so that they're not sneezing in the patient. And you can't stop a sneeze very easily. So if they've got their instrumentation in there and they're doing heart surgery and all of a sudden they got to sneeze, and somebody told me, oh yeah, he can just sneeze into elbow. I'm like, seriously? If they've got your aorta in there, you want them to lift their hand and sneeze. So no, it doesn't work that way. When we look at respiratory protection, because they'll say, well, barrier place cloths aren't respirators. Therefore, I don't need to follow the respiratory protection standard. And I'll go into that a little bit after. Respirators are designed to protect the wearer. End of story. Doesn't protect anybody else. It's the wearer. So then I'm wondering, as time's going on, why is CDC, FDA, why are all these people talking about these barrier face cloths? I'm like, this never, ever entered into my reality. And so I wanted to find out, what are they expecting them to do? So I did find the standard ASTM 35F3502-21, which is the standard specifications for barrier face cloths. Like, wow, never saw that before. And so the definition that they had for what these cloths are supposed to do is to provide a degree of particulate filtration to reduce the amount of inhaled particulate matter from the wearer, which means that I have it on here and they want to try to stop some percentage of it coming out. So that doesn't mean, and I'm going to go over the certification, doesn't mean that nothing is coming out. A certain amount. Well, is that a good amount and not a good amount? Where's the standard on that? So let's see. So how much do actual face coverings reduce the relative risk of COVID? I'm like, are they even working? Are they even worth it? So this little upside down triangle in the industrial hygiene world is the hierarchy controls. So the first thing we always want to do is eliminate the hazard. Well, maybe they're already trying to eliminate the hazard with trying to get rid of people, because that's, again, who's spreading the virus. But that's for the other sessions. So the next one would be engineering controls. How can I get it out of the environment? And then you go, personal protective equipment is the very last one. Well, there's this document, the American Industrial Hygiene Association that I belong to, put out a document in September 2020, reducing the risk of COVID-19 using engineering controls. So I went into that, and when you look at this document, the covering of a person who has COVID reduces your relative risk of getting COVID by 5%. If you mask everybody, your relative risk is 10%. And then if you use ventilation and N95s, you can reduce it almost 90%. So if you look at even really bad ventilation, one air change an hour is actually better than even wearing a face cloth. So essentially, it's doing nothing for you. So then what is the impact with face covering? So if they're wearing it, then what is the impact of putting on this barrier cloth? So there was a study, a retrospective study done by CDC in July of 2020, the community and close contact exposure associated with COVID-19 among symptomatic adults greater than 18, that went to 11 of the outpatient healthcare facilities. These are ones done by CDC. And basically what they did is they wanted to know how many people, what was your mask wearing habit? Did you wear it all the time? None of the time? So if you look at the numbers, and what I always say is the truth in some of these documents always lies between the summary and the abstract, right? So they can say and give you something in the summary and then summary, but all of the truth is really in it. So I want to show you this one chart that is in this, or this one table in there. And I want to look at the last one, the respondents, and how often they were said to have worn a face cloth. So they have always, and they have the never. So when you look at it, the number of people that said they wore masks all the time were 108. The ones that said they never wore it were 6. And you look at the control group and it's the same thing. So basically, what you're doing is looking at whether this actually did anything. And if you're looking at just this one little study, because of course they can show all kinds of little studies, tit for tat kind of thing, is that in general, you are more likely to appear with symptoms and go to the hospital if you were wearing a mask than if you weren't. And as far as I'm concerned, a disposable Kleenex, or do we remember what these are? I used to think these were really gross when people use this and then put it in their pocket. Well, this is exactly what they're asking people to do, and especially the children. Is this mask on your face 6 hours a day? You don't change it, right? This is why they came out with disposable Kleenexes. And then they're asking them to keep this in their face. And there is consequences for that. So being an industrial hygienist and following OSHA's respiratory protection standard for 30 years, that was the standard. This is what we used. This is what all my training was. This is what all my experience was as to how this works. So OSHA standard should be the judge for any other respiratory protective measure or decision, at least the principles in it. I know I can't put this on somebody's face and fit test them. Doesn't seal. And when we talk about fit testing, we use little ampules. So I want you to be able to smell it. So if you can smell it, it means it failed. And the first thing that we would have to do as well is I could not even fit test anybody. I know they wanted to know if I could do a demo of fit testing, put a respirator on, see if they can smell it, do the whole thing. No, I could lose my certification if I don't have medical clearance before we fit test you. So I've gone into people's businesses, and if I don't have that certification that says this person can actually wear the respirator without any issues, I can't fit test them. But what are we doing now? We're throwing everybody in a mask and requesting doctors to give us exemptions to take it off our face. That's backwards. That's upside down. That has no basis in any kind of health assessment. Should we be doing that? And then many doctors don't even want to say that they can. Now, when we go, if I'm doing a fit test and somebody has trouble breathing, then I actually have to send them back out and have the doctor evaluate that. So it's very important anytime that you are going to restrict somebody's breathing that you know what you're doing, because many of the things I just listed here are part of a questionnaire. So the employees have to sit down and fill out, do you have any of these things? Do you have an allergic reactions that affect your breathing? Asthma, skin allergies, rashes, claustrophobia. I'm a big one with the claustrophobia. And these poor children, when I'm thinking of them, is that they probably have anxiety, but yet they have to be in there and you're not able to, they're not able to remove that. So there's really harm there. So that's how, when I look at what they're doing and the response they've been doing, it's just so opposite to everything that is important. Let's see if I can move the next one. It's not advancing. Okay. So what I wanted to talk about is certification. Like, how do we know? So the first thing that part of the OSHA standard is that it needs to be NIOSH certified. And what that says, and even in the standard, so employers can't go and just put anybody in a respirator. It has to be NIOSH certified, and there's a reason for it. And they talk about N95s, where there's also N99s and N100s. N95 just means that it's going to filter out 95% of particulate greater than 0.3. Viruses are less than that. So it's going to predict 95. I can go up to 99. That gives me 99% are filtered, or I can go up to 100. So I know my amount of stuff that I'd be inhaling, it's going to be protecting 100%. So the interesting thing is, do you remember when Kraft flew to China in the beginning and came back with, his airplane full of N95s? Well, our KN95s. And and from China. And I really think the K means knockoff. I mean, I've gone down, the streets of New York City and buying nice, Prada bags and stuff. So essentially this is what they've done too, is, put the K in there. And when you look at it, I just want to show you the difference. So I went and got these. So this is NIOSH certified respirator, N95. See the packaging, see how they're keeping the form and all of that, right? Here's your KN95s. You can get 10 of them in here. It says non-medical use. And who knows what that certification, that GB 2626, I did go look at it. And when I was reading it, I was looking at microorganisms, and it said these little tiny organisms that you can't see under a microscope. I'm like, that's really descriptive of what a virus is or whatever it is that they were trying to do. But I want to get back to the first one, is the barrier face cloths. So this is what we got, right? This is considered a barrier face cloth. So when I looked at it, the standard just came out in 2021. So I did read it, and there's a lot of things in here. And one of the important ones is more research is needed for protective, effective face coverings. So the whole standard I'm reading, there was so many things that said, oh, we can't even just tell you how much leakage of viral material there is. It was so much, it was just, I think, just to put it on the books, because if you were going to go and buy one of these and it says ASTM F3502-21 certified to be worn by the general public or whatever, right? You're likely to buy it, because who's going to go look at what that standard is? Well, when you actually look at the efficacy of what this is supposed to do, it's at minimum to get the certification is greater than 20% submicron filtration. So you're lucky if this is even going to hold 20% in, which is the intent of these, right? This wasn't the intent to protect you, but to protect the other one and what you're releasing. So when it really comes down to is marketing 101, never let a good pandemic go to waste. And I don't mean to make a joke out of this, but what I'm trying to point out is that when I was looking for slide graphics for this presentation, I happened to run across this 5 little set of things you can buy. And I looked at the feedback, and it said, I love how cute and comfortable these are. I like wearing these instead of the generic blue or fabric mask. Fun patterns, nicer quality, and better fit. When I first started in the pandemic, I wore one of these while everybody was wearing these. And then when it became fashionable, I switched to this. And then when I realized that this was ridiculous and that all I was doing is going along to get along, I never put it on again, because I know what the effects are. And I could do it for the 10 minutes to go in to get my sandwich and then go back. But all of the workers that are in your Dunkin' Donuts or in your grocery stores, they're there for 8 hours a day. You're only in there for 10 minutes. So it's easy for you to do it. I'm concerned, or the kids. Why they put the kids in there? 6 to 8, 6 hours a day that they're making them wear them, and they're not even effective. So what is the issue? Oxygen is the quintessential element to life on this planet. And I go back to Dr. Otto Warburg, who won the Nobel Prize in 1931, 31, mind you. Think about this, for the discovery that unlike all cells in the human body, cancer cells do not need oxygen. Cancer cells are anaerobic, absence of oxygen, which means that they derive their energy without needing oxygen. Cancer cells cannot survive in the presence of high levels of oxygen. Okay, so anytime we are covering our mouth and our nose, we are restricting the amount of oxygen that we were bringing in. We are increasing the resistance on our respiratory system, and that can lead to breathing difficulties and other issues. So why this great divide over this piece of cloth? And basically what's happening, in my opinion, and I think in a lot of other people's opinion, is that truth and fact are being replaced with personal belief. And when you believe it long enough, eventually the lie is believed. You think that it's helping, you're thinking you're doing it. And even something, which is why I'm glad that we can at least come out and maybe talk about this, look at it, see what's happening. And when one starts acting on this lie, there is always a high cost and consequence to it, no matter what it is, in any aspect of your life. Face coverings create a breeding zone for bacteria, causing sinus infections, fungal infections in the lungs, creation or exacerbation of existing conditions. This leads to, unfortunately, public policies and decision-making, such as universal mask wearing for children and workers, and they're not okay. And the rest of this panel will, continue to explain that they're not okay. So where do we go from here? Barrier cloth covering should be wear at your own risk. I'm telling you the effects that can happen. And I see so many people walking around outside in the air, nobody around them, driving in their car. That's crazy. Honestly, that's crazy. And then ask yourself, do the random rules and mandates for mask wearing by asymptomatic healthy people make sense now? Can society recover from the physical, psychological, and societal impacts of wearing face coverings for hours, days, and weeks by countless workers and children? When they say that we're going to be living with COVID forever, you're going to be living with viruses forever because humanity has lived with viruses forever. There's a symbiotic relationship between viruses and bacteria and humanity. We need to get a better understanding of our own biome and how we interact with the environment if we are going to actually survive as a species. So I end with, fear less and become fearless. It's just a matter of a space. That's it.
Thank you so much, Tammy. The very beginning of a conversation that I'm sure could take all day. Very well done. Okay, so our next speaker on this particular panel is Lou Tulik. He has a 30-year career in law enforcement. He's an instructor for the Homeland Security Weapons of Mass Destruction program. He also holds multiple certifications of incident command through FEMA, so don't mess with him. Come on up, Lou. I'll get your screen share going. All right. Julie, you want to just come up here and help me with your, it just looks a little different than my computer.
Okay. So we're going to do a stop share. And then we're going to go.
There it is. Okay.
Where did it go? Here we go. Tulak. Closed hands. And then
Perfect.
did we do, we got to do
We have to
screen
screen share
share.
again. Yeah.
And then
Sorry, I just didn't know
desktop
where it went on your screen.
share. And then- Okay, so we're just going to press the arrow key there.
Yeah. If it goes to sleep, you can click this.
Perfect. Thank you. She just said if it goes to sleep, I can click the screen. I'm hopefully nobody here falls asleep. So I want to thank Tammy because first of all, I've spoken before local school boards. I've spoken to the Board of Health in the community I live in. And Tammy, I've done a lot of the research. I've learned a lot of the things that you taught people or what you've just presented today. And I tried to tell school committees that what they were doing was essentially reckless endangerment of children. And if you look up that Mass General Law, it really says if you're knowingly putting a child at risk of injury, you are committing the crime of reckless endangerment. If you read the elements of that statute, you will see that prolonged mask wearing absolutely meets that level. So I've actually told the school committee in the town I live in, I said, you know what? You all should be prosecuted for reckless endangerment of children. Of course, that doesn't go over very well, and they don't really want to speak to me after I say things like that. I sent them 44 studies on masks the other day. The only person to reply to the email I sent to the school committee was the student representative to the committee who said, thank you, Mr. Tulik. Thank you for sending this information. We'll look at it. So what they do typically is they'll tear apart a study because it doesn't meet their agenda or what they feel really works. And they'll say, well, this is misleading or that's untrue. However, they cannot produce a study that tells me otherwise. Not one. So every time I've sent them a study, it's just, well, Mr. Tulik, you're kind of off there. Or this is kind of off. I don't know where you got this from. No matter how you look at it, there's one fact that remains true regarding these masks. I'm speaking specifically of cloth and fabric masks. They do not meet any level of respiratory protection. It's written right on the CDC's website. They even advertise it as such. So putting children to cough and sneeze in masks all day long is absolutely absurd. And when she brought out the handkerchief, I thought of my grandfather who used to pull out a handkerchief. Anytime he coughed or sneezed, I would never imagine my grandfather putting rubber bands on and putting around on his face for the remainder of the day. And that's essentially what we're doing to these children. So that's my tangent on reckless endangerment. And you can ask yourself, does it meet that standard? If you actually look up the law, does it meet that standard? I think it does. And I have spoken to prosecutors, and you'd be damn lucky if you find one who's even willing to entertain the thought of possibly taking a school committee to court for a criminal charges. Of course, we've heard all the civil cases coming up, people charging that, civil litigation against school committees or towns or DESE, Department of Education. because the Department of Education, as far as I'm concerned, has no authority whatsoever medically to tell you what to do with your children in school. What I'm going to do is, because Tammy took all my steam and I was going to talk about masks, I'm going to talk about another area of expertise that I have, which is narcotics. And unfortunately, I don't know if anyone in this room has sat in a room with a dead child for long periods of time, young adults, and I have. And when you do that and you sit there and you're waiting for the medical examiner to come take the body, and you take photos and you talk to the parents and you break some horrible news to them, it's pretty damn sickening. And after you do it 20, 30 times, you get really sick of it. And you want to know why. How could this happen? How could a society like in the United States have such an addiction problem? How did this come to pass? So I would ask kids, most of the time it was young adults, I would ask them if they survived the overdose, come talk to me. I want to find out more. And they would say, I hurt my knee when I was riding my bike. I was 16 years old. The doctor gave me OxyContin. He said it wasn't addictive. Be okay. That happened time and again and again and again. And I would be like, oh my God, what the hell is going on here? So this is the case of Dr. Jama, second highest prescriber of opioids in Massachusetts. He was also prescribing opioids at 11 times the average rate. I want to tell you 5,000 OxyContin prescriptions to 350 patients in 1 year. 2.5 for illegally prescribing opioids. That's what he got for time, 2.5 years. Now, he's a 74-year-old man. I knew him. He was very respectable, very polite, very humble. How does a 74-year-old doctor with no record become the biggest drug dealer in the town of Ludlow? Second biggest drug dealer of OxyContin in the state of Massachusetts. How does that happen? So I went a little further, and of course, a good investigator doesn't simply take a report, take pictures, and close the case. He wants to know more. And I would push and push and push. And then I came upon a book called Dreamland by Sam Quinones. This book basically goes through the entire progression of how we came to where we are with this opioid crisis. And I know what you're saying, or you may be asking, what the hell does this have to do with the COVID crisis? Well, I'm going to tell you. This is called, if any of you have ever heard of the Porter and Jick study, the Porter and Jick study came out on January 10th, 1980. I don't have to read the whole thing, but it's 5 sentences long. And at the bottom, this is a study that said, we conclude that despite widespread use of narcotic drugs in hospitals, the development of addiction is rare in medical patients with no history of addiction. So what we had here in the New England Journal of Medicine, highly reputable, respectable publication, Purdue Pharma got a hold of this article right here. And you know what they did with it? They went to every doctor they knew and they said, hey, we have this stuff, OxyContin, it's about to get approved by the FDA. This is a study right here that cites the fact that it is non-addictive. This little study, which was an op-ed piece and not even a true study, simply an op-ed written to the New England Journal of Medicine, became the fuel that ran this thing across the country. And pharma reps would walk in to doctors' offices like Dr. Jama, and he told me they would bring me gifts, they would bring me baskets, they would bring me suitcases and trips and everything. I'm like, are you kidding me? And he goes, but they also told me it was non-addictive. I thought I was helping people. So when people tell you masks are working, what are they using for evidence to prove they work? And when they tell you the vaccines are working, what are they showing you for evidence? And are they hiding things? Big Pharma used this to fuel the opioid epidemic. Curtis Wright, once the director of the U.S. Food and Drug Administration, who oversaw evaluation for pain medication, got a position with a first-year compensation package of $400,000 at Purdue Pharma a year after he led the approval of OxyContin. It's according to this book, which is an incredible read, Empire of Pain. So these people work together, they help each other out financially, and we are up against a monster if you think this is something easily defeated. Money is the root of all evil, absolutely. Here's this wonderful person here. In a letter to the administration, 28 groups fighting the opioid crisis accused Dr. Janet Woodcock of presiding over one of the worst regulatory agency failures in history. She was the head of the FDA She was in charge of the unit responsible for the approving of new prescription opioids, the Center for Drug Evaluation and Research. Guess where she is now? She's in charge of the FDA. And you know what she just did? She just approved, we believe she approved, a vaccine a couple of weeks ago. The letter urged the president not to nominate her permanently to head the agency. This is the same woman that approved OxyContin is approving approve that last vaccine. This woman should be in prison as far as I'm concerned. United States saw a record number of overdose deaths last year, 93,000 overdose deaths. The opioid epidemic did not go away when COVID came along. That's an increase of 30% over 2019. Now, I talked to my detectives who I worked with. They're going from call to call to going. It has not gone away. It has only got worse. Why is this happening? It's happening because the FDA failed in their job. And are we willing to put our lives in the hands of these agencies once again with COVID? Have we not learned our lesson? It is absolutely absurd. So when I instruct people, I would instruct the first responders in weapons of mass destruction. And a weapon of mass destruction is defined as a nuclear, radiological, chemical, biological, or other device that is intended to harm a large number of people. Sometimes it can be, you can have two. You can have an explosive that spreads a radiological agent. You can have a biological agent. So what I'm getting at, biological is something that I guess you determine COVID would be. And I'm not insinuating that COVID is a weapon of mass destruction. But I am saying that fentanyl should be, because fentanyl goes hand in hand with the opioid epidemic, and fentanyl is predominantly what is killing these people. So this is going to circle back around a little bit to the masks. So fentanyl particles are 0.2 microns to 2 microns, which are really, really small. First responders are required to wear N100 masks. Now, in my entire career responding to opioids or fentanyl, I wore N95s, not even realizing that was not recommended and is totally unsafe. And every police agency out there I know that exists uses N95s for a fentanyl scene. Absolutely inadequate and dangerous practice. They need to wear N100s. I've already checked with my expert here who's confirmed that I'm right. So we're wearing the wrong mask for something that is 0.2 microns. N95s can only get down to 0.3, which is not enough. But COVID particles are 0.1 microns and smaller than fentanyl. So if we're not wearing N95s for something that's bigger than COVID, then why are we wearing them at all? That's what I'm supposed to wear when I go to a fentanyl scene. That's called an N100. I don't know if you have ever heard of an N100 mask, but that requires a safety fit, approval, a doctor's clearance. How many people are getting a doctor's clearance before they don an N95? You're supposed to have one. If your employer is requiring you to wear an N95 at work, you need to have a medical clearance to wear that. This is what I'm supposed to wear, ideally, at the scene of a fentanyl situation, is an SCBA, which is a self-contained breathing apparatus. Nobody's wearing those. So this is interesting. If you look on the far left, the far right, that snake-looking thing, that's a human hair. If you look to the far left, the little red dot, third one up from the left, that's a coronavirus particle at 0.1 microns. That is 1,000 times smaller than the width of a human hair. So when people sit there with their masks with weaves that are much wider, and they have openings on the side of the fabric mask or opening on the side of the surgical masks, I think you can fit a human hair through there, but you certainly can fit many of those coronavirus particles through there. And I think one of the big misconceptions is the difference between an aerosol and a droplet. A droplet will tend to fall to the ground almost instantly. An aerosol can travel through the air with what's known as Stokes' law. Newton's law applies to the droplets, drop to the ground. Stokes' law means that they study particles that can float through the air for up to 2 months, almost 2 months floating in the air, because they don't fall to the ground. So the aerosols also get into the deep tissue of your lungs, the alveoli. And this rings true for weapons of mass destruction. When we talk about ricin, we talk about anthrax, those are things that deposit deep into the lung tissue and cause fatal injuries. The large droplets are usually dealt with in the upper respiratory system. The fine microscopic size coronavirus particles at 0.1 microns go deep into the body. Masks do nothing to stop that. So this is my acronym for MASKS. It's Masking Against Scientific Knowledge Syndrome. And I absolutely believe that if people took the time to actually research things on their own and don't rely on what the FDA and CDC tells you all the time, because they're not telling you the truth and they're telling you things that will get them money. And now I'm going to transition in personally. I think I have a little time left.
1 minute.
Perfect. My daughter, Sophia, she's 17 years old. She suffered from anorexia back in 2017, did 30 days in the hospital, was completely defied all belief when she came out of that hospital and just went on to eat and eat and eat and became an amazing athlete, beat the psychological aspect of it. She just did tremendously well. And then COVID came along. So she had in 2017 did 30 days in the hospital, went through a couple of years, then the lockdowns and the masking, the social distancing, the Zooms, online learning. And that girl devolved. She fell apart in 2020, right after COVID hit. She was regressing. She was starting to limit what she was eating. And then we ended up just, we're going to jump on this. And we did all the hard work we could possibly do to get this girl to avoid it. And we got her through the end of the school year. And then comes along, the school year starting back up, and we're told, well, the masks are going to go back on, the distancing is going to go back on, the arrows in the hallways. And she started to get depressed and upset. And my wife and I were like, what are we going to do? So we did the unthinkable. She's going into her senior year, one of the top runners in Western Massachusetts. We pulled her out of school and we're homeschooling her. Thank you. And I don't need studies and I don't need scientists or doctors telling me what's right or what's wrong. I witnessed it myself. My daughter is thriving better than she's ever thrived in the last 2 years. She's one of the top runners in Western Mass. She wants to go on to college or become an electrician or who knows what, but she is not depressed. She's eating, she's happy. And I want to again thank everyone here who took the time to come out here. I really appreciate you taking the time to listen and learn. And I just want to leave you with that last question. Do you trust these agencies to do the right thing for you and your family, honestly and deeply inside? And if you don't, please do the research yourself. Thank you very much.
Thank you so much, Lou, for sharing such a personal story that really impacted me in this moment. So thank you very much. So our final speaker for this panel is Julie Dietrichson, and she is a registered nurse and is working in a school setting currently. She's been working as a school nurse in Massachusetts for 22 years and has been the lead nurse for her district for 16. Do you have a presentation? Okay, that's fine. Put it back to the mountain. You bet. There you go. Perfect.
Good morning. So I have no slides. I'm basically, I've been a school nurse for 22 years. I became a school nurse because it worked for my family. I'm a mom. I have 4 daughters. And I love the schedule. I have the same schedule as my kids up until the pandemic. Now I work 24/7. It's the worst job right now. I still love it. My heart's still in it, but I literally have no time to do anything except COVID right now. That is my job. In addition to being a school nurse, I'm also a yoga and meditation teacher. And I just want to remind you that being out in nature has the same effect on your brain as sitting in meditation. So this is actually perfect for me. This is my slide. So I was thinking on the way here, I saw this cartoon drawing one time that has kind of stayed with me. It was the picture of 2 mice. And there were 2 of those wheels that they run on. And one of them's running and running and running and running and running. And the other one's just sitting there and saying to the other mouse, I had an epiphany. And it was just sitting, it stopped. And I feel like that's me right now, and probably all of us, that we've just been like running and running and running. And everything is so at this frantic pace and putting out fires, and not much makes sense right now. Not much at all. And I can tell you from the schools, nothing makes sense right now. And to be here, I'm nervous. And my thing is not public speaking. So I'm nervous about that, but I'm actually more nervous because I had to take the day off. And I left my district without a nurse in my building. I'm a high school nurse. And I've left that to my other nurses to cover me. And it's such a huge burden. We can't get nursing subs. No one wants to do this job right now. People are leaving schools in droves. So that's what I'm more nervous about. My heart's in my district. My mind is in my district. But I have to stop that wheel and be here right now because this is really, really important. Nothing makes sense. And for us to be able to have a rational conversation, to stop for a minute and consider what doesn't make sense and what can we do differently? How can we approach this differently in order to be logical and reasonable is really important. So thank you all for being here. So what I've said from the beginning of this pandemic as a school nurse is that we can have two different conversations. We can talk about the virus, which I find fascinating. I'm a science person. I find it very interesting. I like talking about the virus. I'm interested in what it's doing. Or we can talk about the guidelines, the DESE guidelines and protocols, because they don't mutually exist. These guidelines are based more on convenience, or actually inconvenience, in order to get to it's a means to an end as far as what I'll get back to that. That's that's me getting up on a podium, which I guess I have. So maybe I'll go there. I want to talk about the guidelines. So basically, the definition of a close contact is, and has been from the beginning, that if you are exposed to somebody who tests positive for COVID, if you have been within 6 feet of that person for more than 15 minutes, within a 24-hour period, cumulatively, that 15 minutes is cumulative, you are considered a close contact. So my job since the beginning of this is to jump into action when there is a positive case in the school. And what we have to do is we have to then, determine when the person either tested positive if they didn't have any symptoms, or when their symptoms started. We go back 48 hours. We determine who falls into that description of a close contact or definition within the classroom, at lunch, within sports, on the bus. And then we have to notify all of those people. The guidelines, the traditional guidelines from the beginning of COVID, or at least from the beginning, has been that, actually it hasn't been from the beginning, it's changed a million times. It's constantly changing. I can tell you that last year, I knew these guidelines inside and out. I could have conversations about it. I could try to make sense of something that didn't really make sense and feel like, okay, I got this. This year, it's completely different. So the guidelines, as we ended last year, was that if you are a close contact, you are out of school. You can test on day 5 or later. If you get a negative test result on day 5 or later, you do 7 days of quarantine, you come back to school on day 8. That's how we left last year. We come into school this year and there are exemptions now. So there are 4 exemptions to this quarantine protocol from DESE. The first one is that if you are asymptomatic and you are fully vaccinated, you are exempt from testing and quarantine protocols. The second one is if you are on the bus, you are exempt from testing and quarantine protocols because it's a magic school bus now. COVID does not exist on the bus. The third one is if you are in a classroom and you are masked, if you are greater than 3 feet away from the person who tested positive, you do not need to quarantine or test. So you're less than 6 feet, you're a close contact, but you're greater than 3 feet, so you're good. And then the last one, which is probably the only one that makes real sense, is if you've had COVID. You are exempt from testing and quarantine, but only within the past 90 days. So that's another conversation. So those are the exemptions. So this is what it looks like now for me this year. My head is spinning, because if we get someone who tests positive for COVID, what I do is I'm on the phone with the person, the family who tested positive. They're giving me this information because I get the information first before the Board of Health, because it has to go through the Maven and then the local Board of Health is notified. So the school nurse knows first after the parent. I send a text to my administrators who are awesome, and they are trying their best also. Everybody's trying their best. They reach out to the classrooms. They get the class list. They get the seating charts. They determine, and I say to them, I want to know within the past, 48 hours on these days, who was within 3 feet, who was within 6 feet. So they're doing that. Meanwhile, I'm finding out who the person sat with in lunch for those 2 days before. They come back to me with all of this information. I then have to determine who's vaccinated, because then they're just exempt. So I keep putting people into this pile of exempt. Once I've narrowed it down to the people who are subject to the quarantine and testing protocol from DESE, I send a blanket email to all of those who are exempt, basically saying, hey, you were potentially exposed, but by the graces of DESE, you don't need to do anything about that. But please be aware that you may have been exposed to this virus for whatever that's worth. And then I look at these kids who now are not exempt. So what do we do with them? Well, now we have the test and stay program, which is like, oh my God, this is the impossible situation right now. This is what I cannot wrap my head around. So before school started this year, I did a presentation to our school committee just about the testing, because the state is offering 3 different tests right now. You can do symptomatic testing. There's 2 diagnostic tests, symptomatic testing, and then there's the test and stay. Both are used, a rapid antigen test, and are considered diagnostic. We decided, then the other one is the pooled testing, which you may have heard about last year. It's a tremendous ton of work for school staff for like really little return on investment. It's just, it's a colossal waste of time, honestly. Our district decided to do test and stay. And so what that means is that, so these kids who I've identified as being subject to the DESE protocols for testing and quarantine, now we can offer them test and stay. And instead of leaving school, waiting until day 5 to test, and then potentially testing negative and returning on day 8, they can just come to school. And I will test them every day. So I test them day 1, I test them day 2, I test them day 3, I test them day 4, I test them day 5. There's a weekend in there. So it generally ends up being about 5 days. Although, because people who are symptomatic and are testing positive for COVID, they have to use a PCR now for symptomatic. So and that takes a couple of days to get back. So by the time we find out about a positive, we're going back like 5 days sometimes. So the test and stay ends up being a little bit abbreviated. But meanwhile, these kids who are close contacts have been in school. Okay. What we're seeing and what I presented to the school committee at that time was, okay, so pros and cons of this testing. The pros, the kids stay in school. That's what everybody wants. And that's what, is driving DESE, I guess. It's certainly the parents, people have to work. So everyone wants their kids at school. However, logically, if we're having the conversation about this virus, that makes no sense. Because if we're saying, if you don't do test and stay, you're out, and you're not going to test until day 5, because that's when, based on the transmission and the incubation period of this virus, that's when it's more reliable. And also based on the limitations of this rapid antigen test, that's when it's more reliable. But now, come to school and I'll test you each day, knowing that on day 4 or 5, you might pop positive. And now I'm going back 48 hours and I am identifying all the people that you exposed. It makes no sense, and we're seeing it. So when I presented to school committee, like, hey, these are my concerns, but I'll tell you, people want this. They want their kids in school, so fine. But understand that if you have any concern about your child being exposed to this virus, that makes absolutely no sense. We've been in school for 6 weeks. We've been doing the test and stay for 3 weeks. We've had 3 cases of school spread from children who were in the test and stay program. So, logic. It would make sense to me that if we're going to do test and stay, and Desi, are you listening? That if we're saying don't test until day 5, then let's not test until day 5. If we're going to exclude kids, exclude them until day 5. And then we do test and stay day 5, day 6, day 7, and they're in. That's logical. Do I think that all kids need to be excluded? That's a whole other conversation. I'm simply talking about the DESE guidelines, the testing and quarantine protocol. It makes no sense. It doesn't follow what we're supposed to be doing. This testing has a whole other side that for me feels wrong. I'm nurse leader. I am high school nurse. I'm also by default the COVID coordinator. So my name's on everything. This testing thing, I took my name off of because I'm concerned. So CIC Health is the testing provider that's contracted by the state. God bless them. They're doing the best they can. They're building a bridge as they're crossing it. It's been hard. It's been messy. When we started this, one thing that I initially was very, very, very uncomfortable with, and still am, is that when you give consent, when a parent gives consent for their child to participate in this program, they're giving blanket consent to CIC Health for 3 tests, all 3 of those tests that I mentioned, the symptomatic testing, the test and stay, and the pooled testing. They give blanket consent. And I said, hell no. Since the beginning of this pandemic, informed consent has been a huge issue. And it's the basis of healthcare. And I said, I absolutely will not get or facilitate consent for 3 tests when we're only doing 1. That's unethical. And I think it's illegal. And so I tried. So the consent is through this website link. And I said, no, I'm going to print out the paper form. I'm going to modify it so it's only for test and stay. I reached out to the powers that be at DESE and in the state, I don't even know who, and said, I can modify this, correct? And they said, absolutely. Okay. So I did, and clearly said, we are only doing test and stay. You are only consenting to test and stay. And then my superintendent pointed out to me, he was kind of in the system looking at it. And he said, Julie, when we get these paper forms and we have to put them into the system, it defaults to blanket consent to all 3 forms. And I was like, I'm out. I want nothing to do with it. I'm the school nurse. I do the testing. I help to facilitate that, but I have made it very, very clear that I don't want my name on it. And that I make it very clear to parents when you sign up for this, because we've had to go back to this link, that you are consenting to all 3 tests. And if you choose to do so and you're comfortable with that, great. I'm all about, a personal choice, but please understand what you're consenting to, and please understand who you're consenting to, because you're not consenting to me to administer this test. I give you my word that I will only be doing the test and stay program, but you haven't given consent to me. You've given consent to this outside agency. I don't know who they are. And you've given consent, and I'm sure they're lovely people. I think everyone's generally intending to do good, but you've given consent to this outside agency that is not in the school, and I don't work for them. So that's a slippery slope, and it's very gray, and I don't think people really are considering the implications of that. So these 2 blew my mind with their presentations on masks, because I get asked about masks all the time, and I'm like, I don't know. I'm exhausted with it. We're coming into the school year where it was, optional, right? And I knew that that wasn't going to happen. We all knew that wasn't going to happen. And then Desi at the last minute came out with, we're going to wear them just until October 1st. And then, of course, they just pushed it out until at least November 1st. But on October 13th, schools can apply if their district has reached 80% of vaccination rate. You can apply to not wear masks, but only if you're vaccinated. So I asked Desi, I'm working in the school. I asked Desi if we're going to do this, if you're going to allow districts this situation, how are you going to implement this without violating medical privacy and without promoting discrimination? Because you can't. I don't know how we have a list of who's vaccinated and who's not vaccinated, and you can wear a mask, or you have to wear a mask, but you don't have to wear a mask. And their answer is, we don't know. More info to come. Literally, that is the answer. I can tell you, just to wrap it up, that what I have seen since the beginning of this is that my job, like I said in the beginning, is 24/7 COVID. However, it is also, I am a mental health nurse. These kids are not okay. Within the past week, we sent out 2 kids via ambulance because of mental health crisis and suicidal ideation. Within the past week, our school psychologist resigned on the grounds that her position is not sustainable for one person. And I'm telling you, neither is mine. And I am hanging by a thread, and we need help. And so, Desi, if you're listening, you need to fix this because none of it makes sense. Thank you so much.
Wow, thank you very much, Julie, for your thoughts and for the mountain, which I think we all need desperately at this point. So that concludes our first panel on protective and diagnostic measures. At this time, we would like to welcome anyone who is here with us in person to ask any questions of the panel. And for anybody who is watching on our Zoom or live stream, feel free to write questions in the chat. We will probably not get to everything, but we'll try to synthesize common themes and ask some of those questions as well live here for you folks. I see somebody in the back who can get us started off.
First, I'd like to thank the panel for all the extraordinary information they shared. The public has heard this, it's been censored, particularly alarmed by what you said, and I have specific questions with regard to safety for our children in school. First of all, this consent form alarms me. I believe it was or one of the other doctors came out and said, be careful what you're signing in consent. You should be actually signing for the school to consent to give your children shots. So that is something I'd like you to address. Also, the repeated PCR testing, aren't there carcinogenic ingredients in those tests? So between the masks, which have carcinogenic ingredients, mostly made in China, and the tests, what are we doing to our children with this colossal waste of time, as you call it?
Is this on? Can you hear me? I agree. And honestly, I don't know what to say. Every conversation that I have with parents when they ask, when they ask the right questions, we have this conversation, and it all comes down almost to this ethical dilemma that is COVID. What are we doing? What truly is informed consent? Do parents realize that there is, in signing something in order to keep their kids in school, they're sacrificing something? And I think that the drive right now is simply to keep the kids at school without maybe consideration of the implications of that. And I agree. I have concerns about the repeated testing, especially based on the fact that these rapid tests from the beginning, we were told that they're not reliable if you're asymptomatic. So we're testing and testing and testing with a test that we know isn't really reliable. I think the last thing I saw was about 60%, much like the masks. So that is my concern also. As far as the consent to, vaccinate in the schools, I can't speak to that. I know that when there was a push to provide vaccination clinics in the schools, we had a discussion within my district. I love my district. My administration is very supportive, and I've been very honest with them from the beginning about how I feel and where I stand and what I will and will not do. And we had a discussion about a vaccine clinic, and I said that I will not support it. And I certainly, as the head nurse, I will not administer this vaccine within the school setting. And I think generally it was decided that it's not appropriate for school anyway. That it's readily available, and it shouldn't be happening at school. As far as parents giving consent without their knowledge, that I can't speak to that, and I hope not.
Parents do well to send a waiver to school saying, do not touch my child, do not give any medical treatment whatsoever to my child without advising me or my lawyer first.
Absolutely.
Do parents need that protection? Has it gotten that far?
They
always said it was that for children.
Sure. Could we just keep the questions one at a time here? I'll have Julie finish that address
Yeah.
that first part, and then
What
I'll
I
call on you.
what I can speak to is our protocol, and I would assume the protocol in most districts is that regardless of whether you've given consent to test in school, I call before doing that and get real-time consent. They've signed off on it, but I'm also saying, hey, this is what's going on. You've enrolled your child in this program, and here it is. Do you want it or not? And they have the right to refuse that and rescind consent. So I'm doing my best to, keep informed consent pure. Thank you.
Thank you, Julie. So what I'm hearing is really going above and beyond to make sure protections are in place regardless of what it says on paper.
Yes.
I did see a hand, and I want to come back to you if you had anything you wanted to add as well. Yes.
Thank you for terrific presentation. I just want to say I read a book, an interesting book on nonsense recently, and there's no more surefire way to wear down people than to keep spewing them nonsense faster than they can keep up with it, because the logical mind, a person who's rational, wants to make sense of nonsense. So if it's nonsense, it may genuinely be nonsense. I want to ask, I saw a video of a woman who had done tremendous research in Illinois about the financial incentives that school boards were getting for adhering to state and federal mandates. And I imagine not only school boards, but maybe town boards are getting financial incentives, and not just simply free money, here's some money to deal with COVID, but maybe conditional on following these very extreme and harmful mandates. So I'm wondering, among the three panelists, are you seeing this very clear financial connection between, we'll give you this money, help you, even though you're all stressed to an enormous amount, but there are conditions, and it's adherence to this and ensuring that whether it's testing or treatment, that these things are happening.
Thank you.
I don't know. That is an administration question. I do know that when parents have challenged, the mask mandates within schools, what has been explained, or at least alluded to, is that the state, I believe, the threat is to withhold funding that maybe they get anyway, if they're not following this mandate. So I don't know. I can't. Okay, perfect.
I think in our community, it was $1,800 per student they received in PPE, if I'm not mistaken. What they did with that money, I guess you'd have to ask your own. You can actually look these numbers up, find out how much each district received in PPE money. And like I said, my town was $1,800 per student. My daughter's homeschooled, so I'd like that check sent to my house, but I don't think that's going to happen. However, you can draw your own conclusions with what I'm about to tell you. Does anyone know who the previous Massachusetts director of elementary and secondary education was? Okay, his name was Paul Sagan. He did 4 years or 5 years, Sagan, S-A-G-A-N. He did 4 years as our, I think Riley's in that position at the moment. He left in 2019 after Baker appointed him to that position. He left, and he is now on the board of trustees for Moderna. So he also bought $1 million in stock just prior to the epidemic taking hold, and he still sits on that board. So you can draw your own conclusions as to why they're demanding 80% vaccination rate in schools. To me, I'm a detective, I'm not an idiot. I can figure out that there's something that doesn't smell right there. And if you're worth anything as an investigative reporter, instead of doing studies on masks and the effects of what they work or not, whatever, is do your due diligence and read through these things. I didn't read that on the internet. I actually went to their website. I did on the internet, but I didn't read it from some other source. I went to Moderna's website. I looked up the board of directors. I've read every single bio of the people on that board, and he stuck out. And when I read that he was the director of the Department of Elementary and Secondary Education, I couldn't believe it. So you can make your own inferences or your own, thoughts on what you think is going on. But I think there needs to be a little bit more, as far as ethics are concerned, investigations. I mean, as a cop, I can't take $50 gift card from somebody for getting their cat out of a tree. That's illegal. I will get in big trouble. But these people can get away with this and not be held accountable.
Great. Thank you very much. Did you have anything you wanted to add, Tina, on that particular topic?
No, I mean, it's essentially you just got to follow the money. I mean, you can look at it in the beginning for the hospitals. They were getting $39,000 to put somebody on a ventilator. They were getting remdesivir was much more expensive than ivermectin, and a COVID positive case, they got money for that. So it really is, you got to follow the money. There's a lot of more millionaires and billionaires than there were coming out of this than before.
Thank you. We have time for probably one more question. Sorry, I saw your hand first. Red shirt here. With the red shirt, yeah. It's okay.
Just to speak to the funds that schools receive, I sat on the school board in our town. We definitely 2010 the big Obama had the Race to the Top fund. That was when we were all in session and laying off teachers and trying to have money to fund our schools. And this was a way of them saying to adopt Common Core and more district testing, and we will keep money. So after that experience, yes, I do believe that like the federal government out there does take advantage of, like, we were in the recession time, and this was their way of sneaking in the whole Common Core and more testing.
Thank you for that, Julie.
I just have one question about the PCR test, and I'm not sure if any of you can speak to this, but it's my understanding that they are sterilized with something called ethylene oxide, which is a very serious carcinogen, especially when inhaled. So my concern is multiple testing with swabs that are sterilized with ethylene oxide over time. What are we doing to our children that are being tested 4 and 5 and 6 and 7 times, and weeks? And I'm very concerned about those tests. And I think that if we're going to continue to test, we have to address that and not just keep ignoring that. I just feel like it's an ignored part of the conversation.
May I opine on that? This is Dr. Fleming. Can I opine on that?
Sure.
All right. So to begin with, and if you've listened to me enough, I'm not interested in people liking what I have to say. I'm only going to tell you the truth. Ethylene oxide has been used for many years to sterilize equipment, and that's why it's actually being used for that. It's an inexpensive way of doing it. It's really not an important issue with all of this. The important issue is that the PCR test, which is a good test as its inventor, Mullis, described it, stopping at 20 cycles, looking for genetic codes, has been used incorrectly, number one. And so what we have demonstrated with PCR testing is that after many decades of research in medicine and infectious disease, we have learned that infectious diseases that spread respiratorily, in fact, spread respiratorily. Congratulations to humanity, a tremendous waste of time and money. It spreads from person to person. It does not determine whether you are clinically ill. It does not determine whether you need treatment. It simply shows that there's a genetic distribution among the population of this virus. And congratulations. I think we should have already known that. So we've used a test incorrectly for a long period of time. The other thing I caution is that when I watch everybody getting biopsied or sampled from this, I cringe because I don't know where they're teaching people to do this, but you don't go straight up and do a brain biopsy. It's horizontal to the mouth that you're supposed to do. So there's no place that's appropriate in school systems for PCR testing. Children are not a sampling source. It's been used incorrectly. It's not the ethylene oxide issue. It's simply the inappropriate use of the test. And I have a patented test that if you used it incorrectly would be completely meaningless, as was this test.
Thank you, Dr. Fleming, very much.
You're
Julie,
welcome.
just verifying, we have till 11:25 or 11:30?
Well, we were going to take a little break. get
Okay.
ready For the next panel.
Okay.
You want to take one more?
There was,
question?
yeah, why don't we take one more question because I actually
Okay,
jumped in front. No, it's fine. I just wanted to make sure I saw you in the back. I don't know if you guys have collaborated on your questions or if they're two separate.
No.
Okay,
I just actually have a quick comment.
Sure.
As far as the funding is concerned, I own a childcare program and we've seen the same thing in the childcare industry. And I'm actually really concerned about it right now because we're seeing a lot of childcare programs that accept vouchers and things like that that are being, kind of being held hostage by the Department of Early Education and Care. So, they're being told that if they do not implement these type of mandates on children, masks as young as 2 years old, and I suspect that there's a vaccine mandate coming. They're saying that only care providers may have to get the vaccine. They haven't determined that yet. And so we actually pulled our daycare out of Department of Early Education and Care, PMA, and we're refusing to contract with the department as long as they're refusing children. But we have a lot of other providers who are very, very concerned and they can't pull their daycares out of the department because they're receiving federal funding, and they've actually started to give them like incentivizing grants and things like that that we've never seen before to try to like push this new public daycare option, public preschool option, and they're doing it through open for grants and things. So we're actually going to see the Department of Early Education and Care become bureaucracy like it's a real big problem.
thank you for your comment, especially from the early education standpoint. We don't hear as much about that. If you have one quick question, we can probably finish that up before our break. Yeah, you.
I was wondering, as far as the mental health crisis that's happening, if we have a mental health crisis, that's just as much a crisis as any other medical crisis. So are the mental health hospitals just completely inundated? And I worked in the mental health field, and that was almost 10 years ago. And there was a crisis then with children having mental health problems. So if they're seeing a major uptick in these issues, why isn't anybody saying we're having a mental health crisis? And it's because of these restrictions that are put on the children. I can't imagine what my life would be like today if I got masks my childhood. We don't know. So
Great.
why is it being brought to light?
Great question. I see Tammy leaning in
Yeah,
there.
I just wanted to make a comment on that. And I had a group over and there was a woman that was a CNA from one of the hospitals. I'm not going to say which one. And she was losing her job the next day. And what she would do is, again, because she was not going to get the vaccine, and she would go down to the ER and just see what patients are there in order to kind of get an idea, are they coming to the floor, or not? And there was one night she was down there and there was 20 people in the ER. More than half of them were under the age of 17, all behavioral. There was a 5-year-old that came in on a stretcher with trying to slit his wrist. So there is a serious problem with this. These kids are not okay. And everybody that is pushing this and keeping them in mask is responsible. They are accountable for everything that happens. And if they think just because it's coming from DESI or coming from DPH that you on the local level are not responsible, you are responsible. And I think in time, you're going to see it. And when things come to light on this, there's going to be a real darkness of the soul, I think, for a lot of these people that are going along with it. You need to wake up.
Thank you. Great note to end on. So we're going to take about a 5-minute break, and then we will begin with our next panel on the safety and efficacy of the COVID-19 vaccine.